everyone. Welcome to the 5th session. Today we're going to be talking about antibiotics and antivirals and how to improve efficacy and how to minimize harm. My name is Lowell Ling. I'll be your moderator for this session. I'm an intensivist from Hong Kong and a member of the Asia Pacific Sepsis Alliance. We're really privileged to have 5 really fantastic speakers with us today, and one especially from Spain. And that is Dr. Alex Soriano, who's going to begin. And we also have Professor Mario Tumbarello, Professor Matteo Bassetti, Professor Anna Gales, and Professor Mihaela Lupse. We're going to have a broad range of topics, and as you know, we're going to be talking about PK/PD. And so why don't we just jump straight to it? And so over to you, Dr. Soriano. Dr. Soriano is a consultant of infectious disease at the Hospital Clinic of Barcelona. He's the vice president of the European Bone and Joint Infectious Society. He will be talking about PK and PD. So over to you.
PK/PD to combat antimicrobial resistance. This is maybe a complex issue, but we will try to summarize the most important aspects. And now imagine that we are in front of a patient that has a pneumonia, and in the lung tissue, we will find, for example, Pseudomonas, Pseudomonas aeruginosa, and the microbiologist says that the MIC of this Pseudomonas is 0.5. But indeed, what happens is that for every 1 million Pseudomonas, we can find here one that is spontaneously resistant. This one. And then, of course, from here, what we are doing is to start an antibiotic treatment in order to achieve a concentration in the soft tissue, in the lung tissue, that it should be at least several times over the MIC. And then we obtain, imagine, 3 milligrams per liter. And what happens is that we are able to eradicate this susceptible, and the majority of the susceptible bacteria. But unfortunately, those that are spontaneously resistant with an MIC of about 4 milligrams are able to cross this wall that represents the antibiotic that we achieve, not the concentration of the antibiotic we achieve in the soft tissue. And then the process is repeated because now this bacteria has no competition and it's able to again duplicate, and the process repeated and appear another spontaneously resistant mutation. And then the microbiologist says, okay, now the MIC is 4 milligrams, and then we try to increase the antibiotic concentration in the lung tissue, but what happens is that again the process is repeated and we eliminate the susceptible counterpart, but we select for the resistant again. This picture just is to illustrate 2 important concepts. The first important concept is that every step, and this is a general rule, yeah, there are many aspects to comment on that, but as a general rule, what we have to understand is that each one of these steps represents in general 8 times increase in the MIC from the baseline pathogen. So 8 milligrams, 4 milligrams here from 0.5, 32 milligrams from here. So this is a first important point. And the second important point is that the way to avoid this process, the way to avoid this problem, it's easy in the end. What we have to do is to put the highest concentration from the beginning. And by doing so, we are able to eradicate the susceptible pathogens, but also we will be able to avoid the cross of the spontaneously resistant pathogen from the beginning. And by doing so, we will avoid the selection of resistance. So from here, these are the concept, yeah? But this concept has at least 2 definitions that are important for you, for those of you that are interested in reading on this topic of pharmacokinetics and pharmacodynamics to prevent resistance, that are the following. The first one is that we need, as I mentioned, to achieve a concentration that in general is 8 to 10 times higher than the MIC to avoid the selection of resistance. And this is valid for aminoglycosides, for quinolones, glycopeptides, daptomycin, but I put in parentheses for beta-lactams. I will discuss a little bit further. But here emerged the first definition that I wanted to introduce to you. That is that the MIC of the first resistant, spontaneous resistant strain is what we know as MPC, or Mutants Selection Preventing Concentration, MPC. This is the first definition. And the second definition I wanted to introduce is the mutagenic window. The mutagenic window is the concentrations that range from the MIC to the MPC. And this is important because with these two concepts, we can illustrate what happens in my patient according to the dosage, according to the concentration that I achieve in the infection side. If I am achieving a very low concentration below the MIC, we will fail in terms of a clinical cure, but we will not select for resistant if the concentration is below the MIC. If my concentration in the tissue is exactly between the MIC and the MPC, probably we will cure at the beginning the infection, but we will select for a resistant mutant. And then my patient afterwards, when had a recurrent infection, it will be due to a resistant pathogen. And finally, the way is to be on top over the MPC in order to avoid the selection of resistance and in addition to cure the infection. And remember that it could happen just in 3 days of exposure to the antibiotic. So it's very important to cover from the beginning and to start with a very high antibiotic dosages from the first moment to avoid this process. From here, just let me introduce some, I would say, more practical aspects. How to do that? If I have to cover patients with an MIC of 0.5, that it means that I have to achieve at least 4 milligrams or even 8 milligrams in some occasions, because this is the MPC, then with an antibiotic that I am administering IV, I'm not able to achieve this concentration, we can first combine a second antibiotic with a completely different mechanism of resistance. By doing so, I will avoid the selection. Second, another option is to provide higher concentrations by using different ways of administration, particularly local therapy or inhalation therapy, for example, for ventilator-associated pneumonia. And third, and the most important, remember that the rate of spontaneous resistant mutants is directly related with the amount of bacteria. So what we have to do is reduce as much as possible the inoculum, and by doing debridement, draining, removing the infected devices, etc. Because by doing so, we will significantly reduce the risk of selecting resistance. But let me go to the some not only practical, but also real circumstances. This is a paper published now 4 years ago, where the authors is a clinical trial that for sure you remember, comparing Vaborbactam versus Meropenem. And I'm going to focus in the Meropenem arm. Meropenem was administered at 1 gram infused in 30 minutes every 8 hours. And if we focus in the population, I mean, in the patients infected with Pseudomonas aeruginosa, what we will see is that out of the 35 patients that the authors were able to collect consecutive samples, they observed that 9 out of these 35 strains developed a 4-fold MIC increase for Meropenem. So 25% of the patients that received Meropenem, indeed, when it was possible to demonstrate, to evaluate, select for a resistant mutant. So this is something that happens in the daily practice. And what to do? Just let me show you. This is a guide. This is in Spanish, but it's easy to use because it's very clear. And here, if we click in the utility, what we can see is, for example, this concentration of serum beta-lactams. By clicking here, we can simulate which is the concentrations that we achieve with a specific antibiotic. For example, we select Meropenem. Imagine that the MIC of your Pseudomonas is 0.5, 0.25. So we need to get as a target 2 milligrams, that it would be the ideal situation to be at least 8 times over the MIC. And then we can select the dosage. Imagine the one in the clinical trial, 1 gram, bolus infusion, I mean, just 30 minutes, every 8 hours for a specific weight and for a specific volume of distribution that we can change. And here you can see the outputs. This is the trough serum concentration below the target that we are looking for. And this is the time meropenem remains over the, in this case, the MPC. So if we click here, we are also able to see the graphical simulated serum concentrations. And it explains why this dosage was associated with a relatively high selection of resistance. Of course, what we have to do is to modify the dosage. We can increase the dosage up to 2 grams, infuse in 4 hours instead of 30 minutes, and maintaining exactly the same. The rest, we will see that now the trough serum concentration is 2 milligrams, 100% of the time over the MIC, and this is the output. And if we look at the recent clinical trial comparing cafedarocol versus meropenem, and now meropenem administered in 2 grams, 3-hour infusion every 8 hours, what we can see, again, in Pseudomonas, is that using this dosage, the percentage of patients that develop resistance to meropenem was much lower, only 12% in comparison to the 25% in the previous paper. And so this means a 50% reduction by changing the dosage that we are using with meropenem. But even in this situation, unfortunately, it was not possible to completely avoid the selection of resistance, probably because some of the strains had an MIC higher, maybe even 1, then our target in terms of MPC would be 8. And in order to cover this possibility, what we have to do is to administer the drug in continuous infusion. If we move the cursor until here, then it's continuous infusion, the same dose, 6 grams. And by doing so, we obtain, of course, 100% of the time of the MIC, but a higher also steady state concentration, as you can see here in this simulated concentrations graph. So just to finish my 10 minutes, my take-home messages would be that high bacterial population contains spontaneous mutations, and these are particularly common in pneumonia, endocarditis, and in not-drained abscesses. That pharmacodynamic targets to predict clinical success are not equivalent to those for preventing selection of resistant mutants. That the MIC of the first resistant mutant is described as the mutant prevention concentration, and the PK/PD to prevent resistance should be referred to this parameter. But what happens is that microbiologists are not giving us this parameter because it's a little bit complex to elaborate. But remember that for quinolones, for aminoglycosides, 8 to 10 times higher than the MIC would be the correct one. But for beta-lactams, unfortunately, sometimes mutations occur in some points that makes that the MIC, the MPC is so high, more than 64, and then we are not able to protect from the selection of resistance. And in these circumstances, maybe we have to consider for the first 2 or 3 days of treatment. This is important. All this is important for the first 3 days of treatment to combine or to combine with systemic drug or with locally administration of the drug in order to prevent resistance. So thank you so much for your attention.
Thank you, Dr. Alex Soriano. Fantastic talk. I'll just fire the questions. One question from the audience is, could you share that program that you showed on the phone, just for your hospital?
I will put in the chat if you want. It's a program that you can find in the App Store for iPhone or in Android store. If you write Guia Mensa, I will write in the chat. And then you can download it. It's for free for the first month, so you can check it. If in the end you like it, it's €90 per year. And you will find not only pharmacokinetics, but you will find everything in infectious diseases.
Great. And another question about that fantastic app. How did you measure covariate in the software? Covariate, like PK parameters, sometimes change with different population. Yeah, this is a critical point. Of course, the only covariance that you can simulate here, as you can see, is the weight, is the volume of distribution that you can just predict. Your patient maybe here introduces at the beginning the volume of distribution for the standard population, but then you can change it. And these are the 2 variants that you can modify. So this is just a simulation to have some idea on what to do. This is not the software as you can find in the literature.
There are softwares significantly more complex and more and significantly better than mine in this application. This is just something that could help you to orient which is the circumstance you are living. But for more details, you need to look for other softwares. This is mainly an application where you can find everything in microorganisms, syndromes, antibiotics, and utilities, different calculators. So it's more than just a software for that.
Thank you. Dr. Soriano, I have a personal question. So you mentioned in one of your slides that low doses lead to clinical failure of the treatment, and also a low likelihood of resistance developing. Could you just take me through sort of the logic of that?
This is a good question. It's important to understand that when we talk about PK/PD for resistance, it's just for the risk of selection resistance in the infectious foci, in the site of the infection. And I'm insistent that because if we expose a population where there is one single bacteria that has an MIC of 4 and the rest of the bacteria, million bacteria, that has an MIC lower, for example, 0.5, but I put the concentration of the antibiotic below 0.5, you are not killing the susceptible bacteria, and so never the resistant one will win, because it's necessary to destroy the susceptible one in order to the other one that has a significantly less fitness could overcome and could overgrowth. Yeah. So this is just a concept, but it does not mean that if you administer an antibiotic at very low dosages in another sites, I mean, in the gut, in the skin flora, you can select for resistance. Yeah. This is another topic that I did not enter because it's a lot of questions, a lot of topics for these 2 minutes.
Understand, very clear. One last question. One of the audience asked about toxicity. What's sort of risk of balancing sort of such high MICs or such high drug levels, and how long should you give the antibiotic?
Yeah, this is a great question. Well, for beta-lactams, remember that, and is where we have to work more with beta-lactams, are quite safe drugs. Indeed, up to 64 and even higher concentrations, but at least at the 64 are relatively safe. And so extended infusions or continuous infusion, for example, to maintain 20 or even 25 or 30 milligrams are quite safe. And the second point, remember that, as I mentioned, this is for the first 2-3 days of treatment, because the number of resistant bacteria is significantly lower. So with 3 days, we will be able, if we are doing well, we will be able to kill the resistant bacteria. And from day 3, you de-escalate also the dosage. Not only the other drugs that you started, but also you de-escalate the dosage. Yeah. So reducing the risk of potential adverse events. For 3 days, high doses beta-lactam, it's not a big issue in terms of toxicity.
Thank you. I think that was a great talk. I'm sure everyone learned a lot about PK/PD and AMR development. Thank you again, Dr. Soriano. And next we're going to move to Professor Mario Tumbarello, who is Professor of Infectious Disease at the University of Siena. He is an infectious disease consultant, and his topic today is about Meropenem, Vaborbactam, which is probably a new weapon coming to your ICU very soon. So over to you.
Thanks for the presentation. And the topic of my presentation will be Meropenem Vaborbactam, the result of the old Meropenem with the new beta-lactamase inhibitor Vaborbactam. The registrative trial of Meropenem Vaborbactam was based on the urinary tract infections. That is a usual situation for the new antibiotics against gram-negatives. The drug has been tested in complicated urinary tract infections, including pyelonephritis, with a comparator that was Piptazo. And based on this registrative trial, the drug has been approved by FDA for complicated urinary tract infections initially. But most important trial is the Tango 2. The Tango 2 is a specific trial focused on carbapenem-resistant Enterobacteriaceae, and the design of the trial is very interesting. The limit of the trial is the number of subjects included. It is less than 50 patients, 32 in Meropenem Vaborbactam and 15 in best available therapy. All the results are in favor to Meropenem Vaborbactam, 15% of mortality for Meropenem Vaborbactam versus 33% for the best available therapy, the clinical cure, and also the renal related adverse events are all in favor to Meropenem Vaborbactam. All the outcomes are better for Meropenem Vaborbactam than the best available therapy. Meropenem Vaborbactam is a spectrum of activity that is the same of the old meropenem with the inclusion of the KPC producing Enterobacteriaceae. The drug is not active on the OX enzyme and the metallo-beta-lactamase producers, but is a very good drug for the KPC producers. In this study, including a lot of KPC producing isolates, the result is very good for Meropenem Vaborbactam with inhibition in 99% of isolates. But some papers indicate the possibility to have a resistance to Meropenem Vaborbactam. In this paper, the probability of resistance is low, but not very low, is 8% of the isolates. Is the same that we observed also for Ceftazimib-Bactam. The diffusion of Meropenem Vaborbactam in the plasma and in the epithelial lining fluid is good, is similar in plasma and the epithelial lining fluid. If we compare the data of Ceftazimib-Bactam, Meropenem Vaborbactam, and Imipenem-Bactam, the ELF penetration is better for Meropenem Vaborbactam. In this review, consider the difference between Ceftazimib-Bactam, Meropenem Vaborbactam, and the consideration in favor of one of the or of the other drug. Of course, none of the drug is a good drug for metallo-beta-lactamases. Ceftazimib-Bactam works on OX enzyme, and Meropenem Vaborbactam don't work on OX enzyme, but Meropenem Vaborbactam is very strong in the treatment of KPC-producing infections. In addition to the data of real life of the clinical trial, we have the data of real life. Very few data. This is the first one, a case of a transplant, a liver transplanted patient with an access caused by Klebsiella resistant to Ceftazimib-Bactam, successfully treated with Meropenem Vaborbactam. This is a report of 20 patients with different infections, bacteremia, pneumonia, but also skin and soft tissue infections, intra-abdominal infections, with an overall survival rate of 90%. This is a paper with including 40 patients, clinical success in 70% of patients, mortality in 7.5%. This paper compared Ceftazimib-Bactam with Meropenem Vaborbactam, about 100 patients in the Ceftazimib-Bactam group and 26 in the Meropenem Vaborbactam group, with any significant difference in the outcome between the two drugs. And this is the larger study, including CRA and also Pseudomonas. And the result of the Meropenem Vaborbactam are good for both the infections. And this is the result of the compassionate use of Meropenem Vaborbactam in Italy, about 40 patients. The most important thing is that the outcome of the infection are not related to the susceptibility to ceftazimab-bactam. In other words, the ceftazimab-bactam resistant isolates have the same outcome of the ceftazimab-bactam susceptible isolates if treated with meropenem vaborbactam. And at the end, some word on metallo-beta-lactamases. As I said, the meropenem vaborbactam is not active on metalloenzymes, but some experimental studies indicate that meropenem vaborbactam, in particular vaborbactam, if used with aztreonam, has a synergistic effect also on metalloenzyme. And based on this, recently a paper has been published treating 3 patients with ceftazimab-bactam resistant isolates with meropenem vaborbactam plus aztreonam, and 2 of these patients has been identified as metallo-beta-lactamase producers. This is probably a tentative to do a homemade aztreonam vaborbactam, but probably is only a disparate resource for a disparate situation. At the end, meropenem vaborbactam has a strong activity against KPC-producing Enterobacteriales. PK/PD characteristics suggest that the possible use in ICU in preterm-acquired pneumonia and ventilator-associated pneumonia. The activity of meropenem vaborbactam on oxenzyme and metallo-beta-lactamase is not good, and in addition, on the other non-fermenting gram-negative, the Pseudomonas and Acinetobacter, probably the activity of meropenem vaborbactam is similar to the activity of meropenem alone. Thank you for the attention.
Thank you for the great talk, Professor Mario Tumbarello. We're just waiting for some questions in the chat. But meanwhile, can I just get an idea from you? You've presented all the sort of survival benefit and also clinical efficacy. Any downsides to the drug?
The drug has a good probability to have clinical efficacy, of course. The clinical efficacy and survival sometimes are very similar. Of course, if you consider clinical cure is different from mortality, but both are an indicator of a good efficacy of the drug.
Got it. And any concerns about the tissue penetration part about Vaborbactam? Like, does it go everywhere that the meropenem can go?
At the level of the lung, the penetration is very good. We have seen the data for the penetration in the epithelial line fluid. Probably is better than the penetration reported for ceftazimab-bactam or imipenem-vaborbactam.
Right. Sometimes we use meropenem for hospital-acquired CNS infection, so cerebral, say, ventriculitis.
Yes.
Does it go into the brain?
Yes, I think probably yes. There is nothing reported in the medical literature at this time.
Thank you. And lastly, because I don't have this drug from Hong Kong, is it expensive?
Of course, just like all the new drugs, is expensive. Not more expensive than ceftazimab-bactam or cefiderocol and so on.
Thank you. Well, there are no questions from the audience, but I thank you very much for your time, Professor Tumbarello.
Thank you to you.
Thank you. Have a nice day. Okay, so thank you very much, audience. Next, we then move on to Professor Matteo Bassetti, who is a professor of infectious disease at the University of Genoa. He is president of Italian Society of Anti-Infective Therapy, and he's going to be talking about Remdesivir and novel antivirals and whether it's time for them to shine.
So many thanks for your kind invitation. My task would be to talk about the role of antivirals in the management of SARS-CoV-2. So these are my disclosures in the past 5 years, research grant, advisor, consultant, and speaker. So what do we know about the COVID? COVID is classified in general in 2 progressive stages according to the severity. We have the first stage, in which we have in general typically a very high viral response phase, and this is the early phase of the disease. And then we have the stage 2, that is the stage in which you have in general the hypoxia, and in which in general we have the hospital admission, and there is a relationship between the viral response and the post-inflammatory phase. And then we have the phase 3, the stage 3, in which there are more severe manifestations, and in general patients are intubated or mechanically ventilated. And in this phase is the phase in which there is a very high inflammatory response phases. So actually, there is a role for several different drugs in managing COVID-19. So we have the pre-exposure prophylaxis with the vaccine. Then we have the post-exposure prophylaxis with the monoclonal antibodies by subcutaneous way, or the treatment for outpatients, treatment with monoclonal antibodies, but even for hospitalized patients. And then we have the role of antivirals. And as you can see, we have actually oral antivirals that should be used as in the outpatient setting, but also in hospitalized patients, and IV antivirals, or also in patients hospitalized with severe form. And then obviously we have other drugs like steroids, IL-1 blockers, or IL-6 blockers. So it's important to know that recently we published the Italian guidelines on management of COVID-19 with the two societies, the Italian Society of Anti-Infective Therapy and the Italian Society of Pulmonology, in which you can see very well that we gave some recommendations. First of all, lopinavir ritonavir should not be administered to hospitalized patients, so there is not anymore any role for lopinavir ritonavir. The same is regarding remdesivir. Pending further results from large randomized clinical trial, administration of a 5-day course of remdesivir should be considered in hospitalized patients with COVID-19 requiring oxygen supplementation. So in our guideline, the only drug recommended to be used, the only antiviral to be used in COVID-19 is remdesivir. Hydroxychloroquine should not be administered, and then we can discuss other antiviral that should not be administered for treating COVID-19 in hospitalized patients, unless they are administered within randomized clinical trial. Obviously, these are recommendations for hospitalized patients, not for non-hospitalized patients. For non-hospitalized patients, I will review the data at the end of this presentation. So what do we know about remdesivir? So remdesivir is a drug with a very high potent in vitro activity against coronavirus, SARS-CoV-2, but also SARS-CoV-1 and the MERS-CoV, and favorable effects in animal MERS model. And we start using remdesivir in the early phase of COVID in the compassionate administration in the first phases of the COVID-19 pandemic. So the first trial for remdesivir was the one published by Bagel in New England Journal of Medicine in October 2020, in which remdesivir for 10 days has been compared with the placebo. And they have used in this study the clinical status ordinal scale from 1, that was a patient with no limitation and not hospitalized, to number 8, that was considered a death. And then I invite you to consider, particularly for critically ill patients, these two situations: hospitalized and requiring non-invasive ventilation, and hospitalized on invasive mechanical ventilation or extracorporeal membrane oxygenation, the ECMO. So the data are in this first trial were encouraging, because the data show a shorter time to recovery. You can see 10 days for remdesivir compared to 15 days in placebo. And what was important to see is that there is an advantage, particularly in patients with severe disease. So in patients with severe disease, the time to recovery even more pronounced than in patients with the moderate disease. So, and then when they analyzed the progression of disease, was important to look that there was an important benefit in patients with low flow oxygen support, but even in high flow oxygen support. And you can see the reduction in the progression to ventilation or to death, particularly in these type of patients, and also the incidence of the use of oxygen, high flow, and mechanical ventilation, lower in patients treated with the Remdesivir. And in some patients, Remdesivir was also able to reduce the mortality. You can see, particularly in this setting, there was protecting, particularly in patients with low flow oxygen. Remdesivir was associated with a 70% significant reduction in mortality in this type of patients. So from this first study by Belgium, I think the data were quite encouraging for the drug. So then the second trial was the one published by Goldman, in which they analyzed if all the patients should be treated with 5 days or 10 days. And this was a comparison between 5 and 10 days. And at the end, the observed rates of clinical outcomes at day 14 were similar for 5 or for 10 days. And for this reason, the drug has been finally approved for 5 days of treatment, not for 10 days. So you can have a 5 days course of Remdesivir. These are the two trials published in New England Journal of Medicine. Then there is a third trial that is called the WHO Solidarity Trial that was developed by the WHO, but it was a very confused trial with a lot of arms. Was a phase 2-3 adaptive multicenter randomized open label trial of the safety and efficacy of in COVID-19. Remdesivir, lopinavir, ritonavir, interferon, hydroxychloroquine. Very complicated, but the data were not so encouraging, because looking at the data, they were in the Solidarity published in 2020. There was no impact of Remdesivir in reducing the mortality. You can see the overall in both the patients in ventilated and in non-ventilated patients. So this was a negative trial, and you can see the data published in New England Journal of Medicine. And at the end, there were no benefit in using Remdesivir. Even the diamond was little b didn't cross the line. And for this reason, at least in this trial, there was not advantages in using Remdesivir. Then there are other studies. This published in Lancet Infectious Diseases in 2021, and they include 157 participants assigned to Remdesivir plus standard of care or standard of care only. And the primary endpoint was clinical status at day 15, measured by the WHO 7-point ordinal scale. And you can see here the data of Remdesivir or the control arm, and you can see that at the end there was a kind of advantage in patients treated with the Remdesivir, particularly in the severe form. You can see the important difference in this other study. And then the last study is the discovery one, and in an exploratory subgroup analysis, the hazard for the composite endpoint of the new mechanical ventilation ECMO or DEF was lower in Remdesivir group than in the standard of care. And the median time from the onset of symptom to Remdesivir initiation was 9 days. So there is, even from this study, important messages in favor of Remdesivir. And we recently published our data of our institution, in which we try to compare the two periods, the first and the second COVID-19 wave in my hospital. And as you can see, we increased significantly the use of Remdesivir from the first wave to the second wave, from around less than 3% to close to 40% of the patient treated. And we were able to demonstrate, obviously, based on the similar characteristic of the patients, similar for severity, a reduction in mortality from 21% to 10%. So it was obviously not related only to Remdesivir, but Remdesivir and the corticosteroids, that were the two drugs that were increasing the use, were able to have a significant reduction in mortality. So then other studies is the one of the called PINE3 study, in which 526 non-hospitalized patients with COVID and high risk for progression. And the primary endpoint was COVID-19 related hospitalization. And this is again to compare Remdesivir and the placebo group. And there was an advantage in using Remdesivir, not only in hospitalized patients, but even in non-hospitalized patients. And you can see the data for Remdesivir. And actually Remdesivir is approved not only for treating patients hospitalized, but even for treating patients non-hospitalized. The last two messages are regarding oral antivirals, in particular molnupiravir, that is the nucleoside analog. In the preclinical studies, the activity against coronavirus, including SARS-CoV-2, and in the phase 2 of 202 unvaccinated patients, time to viral RNA clearance was decreased in molnupiravir compared to the placebo. And the other important data for molnupiravir come from the MOVE-OUT study, in which the primary endpoint was the incidence of hospitalization or death at day 29. And the molnupiravir demonstrated to be superior at the interim analysis. And the primary endpoint was 7.3% in the molnupiravir arm and 14 in the placebo arm, incidence of hospitalization of death. So for this reason, the molnupiravir has been approved to be used in non-hospitalized patients. And here you can see the Kaplan-Meier analysis of molnupiravir and the placebo. In the second oral antiviral available is matrelvir ritonavir, that is called Paxlovid, and is an inhibitor of the main protease, is a protease inhibitor. Ritonavir has the role as just a booster, and there is a potent in vitro activity against SARS-CoV-2 and reductions SARS-CoV-2 lung titer in the mouse model. And even the data for Paxlovid has been published in New England Journal of Medicine. And you can see here the data for the placebo and for the Paxlovid. So the result was very interesting, because treatment of symptomatic COVID-19 with Paxlovid resulted in a risk of progression to severe COVID-19 that was 89% lower than the risk with placebo, without evident safety concern. So for this reason, these two drugs were approved, and this is the analysis regarding the death or regarding the adverse events. Again, there were lower death and lower adverse events in patients treated with Paxlovid. So this is an overview regarding the antivirals, and maybe in the future we will have other antivirals available. I would like to thank all of my collaborators for doing a great job in the past 2 years in managing COVID-19 patients, even with the antivirals. Thank you very much for your kind attention.
Thank you very much, Professor Bassetti, for the great talk. We're just waiting for some questions from the audience, from the chat, but maybe I'll start off. I'm an intensivist from Hong Kong, and one of the things that I'm seeing now in the ICU is very strange organizing pneumonia, or some patients who are immunosuppressed and they have prolonged shedding of the virus, let's say a month, 2 months, and they have persistent respiratory failure and they've been given a course of antivirals. Do you have any recommendations on whether to give another course of antiviral in these patients who just doesn't seem to be able to shed off the virus?
Yes, I think you're right. So we did that not recently, because actually the situation is much better compared to just 3-4 months ago. But we did sometimes in an individualized way. I mean, I cannot say that we can recommend for all the patients, but case by case, if you have a patient in which you have the viremia, still viremic after the normal course of Remdesivir, I think these are cases to be manage eventually with the second or even eventually the third course of antivirals. So we did that also in combination with the or other antivirals, so particularly in immunocompromised patients. So we combine Remdesivir plus Paxlovid, for instance, and we also combine, not recently, but during the Delta spread with the monoclonal antibodies. So Remdesivir plus monoclonal antibodies. So again, these are cases that are obviously not labeled by the agency of drugs, but I think case by case you can do that. I think particularly when there is, we can consider not a failure, but when the patient continue to have shedding of virus. These are particular situations in which we probably would probably use antivirals.
Thank you. And one of the questions I had was, my understanding of the literature was that a lot of the trials looked at time from symptom and using that as an indication to enroll into trials. And one of the problems we have now, particularly with the vaccinated group, is a lot of them are asymptomatic, perhaps for a quite long time, and then they develop respiratory failure a bit later, which is slightly different to the original pandemic, what it looked like. Do you have any recommendations on how to prescribe antiviral, say, against an objective measure like perhaps the CT value?
So in general, the experience we have with the antivirals, in general, regarding particularly the oral antivirals, were used based on the time to symptom develop. So, and you should use this drug in the first days after the symptom onset, no more than 2-3 days. Otherwise, they gonna be not working anymore, because we know that the higher viral load is present in the first days after the symptom onset. So this is in the general population. So then obviously, again, I think it's really depending on the case. So if you have the patient that develop symptoms after 10-15 days after he become positive, I think, or he or she become positive, I think you should decide based on the patient, and maybe you can use the antiviral. So because actually we don't have too many options, unfortunately. Sotrovimab, that was very active against Omicron 1, is not so active against the Omicron 2. So we don't have the possibility of using a monoclonal antibody, at least empirically, because Omicron 2 is predominant. So in this scenario, I believe that Remdesivir IV remain the only potential options for reducing the viral load. And I really believe, even if the times of symptoms, of the time of after the beginning of the positivity of the swab is longer than 5 days, maybe you can decide based on the symptoms, and obviously on the sign of the CT scan also.
Thank you. There's a question from the audience, and he or she is asking, what's the best way to document shedding? Do antigen tests suffice?
In general, the viremia, because if you have the positive swab or a measurement of the viral load, because this is obviously the best way. So in general, we do that not only in blood, but we can do eventually even in the BAL. So measurement of the viral load, and which is the number of cycle at the PCR test.
Thank you. There are no other further questions, so I think we'll thank Professor Bassetti for a great talk, and then we'll move on to the next speaker. The next speaker is Professor Anna Gales, who's Professor of Infectious Diseases at University of Federal at the Sapello. She is a great researcher in molecular epidemiology of multi-drug resistant bacteria, and also interest in vitro activity of new antimicrobials. She's going to talk to us about Colistin and Fosofmycin, and her question to us is whether it's the end of an era or the requisition of potent drugs. So over to you, Professor Gales.
Hi, thank you very much for the organization, for the invitation, and thank you very much for the kind introduction. And here are my disclosures. And I would like to start my presentation. Just remember about the new antimicrobials that were recently approved for gram-negatives, for treatment of gram-negative infections. Most of these agents are combinations of beta-lactams with beta-lactamase inhibitors. They will target carbapenem-resistant Enterobacterales. Very few will have activity against carbapenem-resistant Acinetobacter. Aliás, none of the new combinations with beta-lactams and beta-lactam inhibitors have activity against carbapenem-resistant Acinetobacter. And none of them also will have activity against MBL producers. Unfortunately, as expected, we have observed a rapid emergence of resistance against the new agents. So the new agents, as soon as we introduce them in the clinical practice, we will observe the emergence of resistance as expected. In this context, I hope after the end of this presentation to convince you that there is still a clinical role for polymyxins and fosofmycins, which are old agents that were developed before the current clinical standards that we use nowadays. So polymyxins, they have available only polymyxin B and polymyxin E, that's also called Colistin, that are available for clinical use. They have a unique mechanism of action. The main mechanism of action, they will displace calcium and magnesium that are close to lipid A of the LPS in the outer membrane. They will cause a break of the outer membrane protein, and they will enter in this break and via a self-wave pathway, and will act in the inner membrane, and they will destabilize the inner membrane. They will have also an activity against inhibiting the NGA2, and they have also nowadays another mechanism that's a vesicle-vesicle mechanism. Polymyxin B is also known by activity of endotoxin, and they have in vitro activity against Acinetobacter, Pseudomonas, E. coli, and Klebsiella. Polymyxin B and Colistin, they are very similar to each other. They have a very common chemical structure. They have a very common spectrum of activity. What they are really different is the pharmacokinetics. The drugs are really different. But otherwise, the other parameters, even the mechanisms of resistance, are very similar. The reference technique for antimicrobial susceptibility of polymyxins, according to CLSI and EUCAST, is broad microdilution, and the results are influenced by many factors, by the cation content of the Miller-Hinton agar, is influenced by the quality of the plastic trays that I use to run the broad microdilution. So we have many problems with the antimicrobial susceptibility testing of polymyxins. We do also have problems with PKPD issues. Concentration of polymyxins in serum are highly variable and may be inadequate for effective bactericidal activity. They have a narrow therapeutic window. To have like a rapid bactericidal effect, I will have for severe infections a concentration needed around 2 micrograms per ml to have a reduction of 1 log to 10 bacterial count. And this is also the concentration that's very close to have nephrotoxicity. We have also a problem with the concentration in the pulmonary epithelial lining fluid. It's very common, it's very, many times when I prescribe the common regimes for polymyxins, I cannot reach the adequate concentration in the pulmonary to have a treatment of pulmonary infections. We have also observed a clinical failure, emergence of resistance to polymyxin monotherapy. We have a hetero-resistant population. And with fosofmycin, we have fosofmycin trometamol, that's the oral formulation that's available in most countries of the world. But the fosofmycin disodium, that's the intravenous formulation, is not available in all countries in the world. For example, it's not available in the United States, it's not available in Brazil, and we hope to have them soon. It has also a unique mechanism of action. It blocks MOR1 activity, leading to the cell death. It inhibits the peptidoglycan synthesis. It's a very safe drug. It has a reliable in vitro activity here in this slide, because in my presentation I focus on gram-negative bacilli. It has activity against Enterobacterales, it has activity in multi-drug-resistant isolates, but it does have activity against Staphylococci aureus, it has activity against Enterococci. The antimicrobial susceptibility test, the reference, is the agar dilution technique, and we have only breakpoints for disk diffusion for E. coli and Citrobacter according to the EUCAS breakpoints. Right now, there is open consultation for EUCAS for the evaluation of the fosofmycin breakpoints. Fosofmycin is a small molecule. It has activity in biofilms. It also has activity against bacterial, intracellular bacteria. It has a immunomodulatory activity, it has been speculated. But we also have, on the other hand, the emergence of in vitro resistance. Many times, it's very easy to select for resistant isolates in vitro, but it's very difficult but it's difficult to find them in the clinical setting, because we believe that these isolates that are resistant, that were selected in vitro, they have a lower bacterial fitness. They don't resist, like they have their metabolism is not so good to survive. Fosofmycin was recently evaluated compared to ceftriaxone and meropenem for treatment of bacterial urinary tract infections due to multidrug resistant E. coli. So the idea was, fosofmycin, is it no inferior to ceftriaxone or meropenem? It was ceftriaxone or meropenem. It was an open clinical trial randomized, and the patients were randomized 1-to-1. One patient would receive fosofmycin 4 grams every 6 hours, and the other group would receive ceftriaxone or meropenem. They would receive meropenem if the isolate was resistant to ceftriaxone. And the primary outcome was the combination of the clinical and microbiological course 5 to 7 days after the end of treatment, and they were expecting a non-inferiority margin of 7%. However, the fosofmycin response was 68.6% compared to 78%, and it did not reach the non-inferiority margin that they were expecting. So, in this study, the fosofmycin did not show to be non-inferior to ceftriaxone and meropenem. In addition, there was a number of patients that were withdrawn because of higher adverse effects. So, it's unfortunately, it was not a positive outcome, but at least in very selected few patients, maybe it can be used as an alternative therapy for carbapenem-sparing regimens. In the IDSA guidelines, I want to cite where they cite polymyxin and fosofmycin. Fosofmycin was not cited by the IDSA guideline because it's not available in the US, but polymyxin was cited as an alternative therapy for treatment of urinary tract infection caused by carbapenem-resistant Enterobacterales or difficult to treat Pseudomonas aeruginosa. Because in this case, it's used as a urinary tract, colistin was preferred over polymyxin because the concentration of colistin are higher in the urinary tract than polymyxin B. For therapy of treatment of carbapenem-resistant Enterobacter infections, for mild infections, they recommend monotherapy and polymyxin B as an alternative therapy, except if it was a urinary tract infection. In this case, you should prescribe colistin. For moderate or severe infections, they recommended the use of combination therapy, but they advise not to combine with rifampicin and carbapenem, despite having like in vitro synergy studies showing that there is a good combination. This is because you have two randomized clinical trials that we can question them about the results, but they show that there was no benefit combined rifampicin and carbapenem with polymyxin for treatment of CRAB infections. If you look, just a quick reminder, the last slide, I talk about the IDSA guidance document. It's not a guideline. Here, I'm going to talk about the ischemic guideline. This is a guideline. The other one was just a guidance document to guide doctors in the US how to prescribe antibiotics for these difficult to treat pathogens. Here, in the ischemic guidelines, the polymyxins and fosofmycins were cited for the treatment of carbapenem-resistant Enterobacterales, carbapenem-resistant Pseudomonas aeruginosa severe infections, and carbapenem-resistant Enterobacter infections, all of them for severe infections. They recommend for CRE, they recommend polymyxin or fosofmycin only if the new beta-lactamase inhibitors combinations are available, or if there is susceptibility only to polymyxins, aminoglycosides, or fosofmycin. In this case, for example, an MBL producing isolates. If I have an isolate that's producer of methyl-beta-lactamase producer, maybe can be susceptible only to polymyxin. For carbapenem-resistant Pseudomonas aeruginosa severe infections, they recommend to use polymyxin only if there is in vitro susceptibility, and we also should combine. This agent should not be used as monotherapy. They recommended they to be used as combination therapy if there is susceptibility in vitro. For carbapenem-resistant Campylobacter infections, they also recommend combination therapy, including 2 in vitro active antibiotics. In this case, because fosofmycin has no activity, they recommend polymyxins combined with another agent. They also recommend not to prescribe rifampicin or carbapenems for treatment of Crab infections. I just would like to call attention that every time that you prescribe polymyxin and fosofmycin, you should use at least 2 drugs for the treatment of the patient, mainly if we also love to use if they have susceptibility in vitro to both drugs. I just would like to call your attention to the strength of the recommendation. The strength of recommendation is conditional, and the level of evidence is very low for carbapenem, Pseudomonas aeruginosa, and Crab infections, and the level of evidence for CRE is moderate. I would like just to mention that's just a systematic review of clinical studies. We have other studies. I just want to cite this the study that was conducted by Dr. Alessia Savoldi, that they had a systematic review, and they conclude that they found methodological issues and bias in the existing studies. That's impossible to conclude what's the best strategic therapy. It's impossible at this moment to affirm that monotherapy is superior to combination therapy or vice versa when you are treating Crab, CRE, or carbapenem-resistant Pseudomonas aeruginosa infections. So at this moment, we do not know if monotherapy or combination therapy should be prescribed for treatment of this very difficult treat infections. Just like a systematic review and meta-analysis that consideration only time Q studies and PKPD models that evaluated the combination of antibiotics that showed high synergistic rates. So we have the many studies that have shown that colistin combined with rifampicin or with carbapenems, with Bactrim, or even polymyxin with fosofmycin can have like a synergistic activity in vitro. So I am not completely like, because combination therapy depends very much of the isolate that I am looking for, that I'm testing, because depending on the mechanism of resistance, one combination can be synergistic or not. I also would like to call attention that because of the rapid emergence to the new agents, we have also authors that have combined fosofmycin or with ceftazimab-bactam, ceftolozumab-tazobactam to prevent the emergence of resistance to the new agents. We have also the combination of colistin and fosofmycin against MBL producers. Just an example, this is the carbapenem resistance rates found among gram-negative bacilli causing central catheter-associated bloodstream infections in patients hospitalized in ICU. Each bar represents 1 year. So you can see that we have very high rates of carbapenem resistance in Brazil. So just to have an idea, about the new agents that were approved in the US and are available in the US and Europe are not available in Brazil. And I believe that's the situation in many Latin American countries and also in many other countries of the world. So by April 2022, we had only approved for clinical use ceftolozumab-tazobactam, ceftazimab-bactam, and delafloxacin. So in this way, I do not have the new options to prescribe for these infections. So in our lives, polymyxin B or colistin are still used as a therapy, a first-line therapy for treatment of carbapenem-resistant Enterobacter infections, for example. I just would like to finish my presentation with like many quick messages that polymyxin in places where we have the new available therapies, polymyxin have been regarded as an alternative therapeutic agent due to their toxicity. Nobody questions that they are very nephrotoxic drugs. They have also neurotoxicity, but they do also have a good clinical in vitro activity and clinical activity. It has been also as an alternative agent for CRE, especially in places like Brazil, where the new beta-lactamase or beta-lactamase inhibitor combinations are not widely available, or you have only in vitro susceptibility to polymyxins, like in the case of the MBL producing isolates. They have been recommended as a first-line agents for treatment of severe carbapenem infections. Nowadays, we have ceftriaxone, but ceftriaxone has a warning because of the increase in the number of the patients who could have died using ceftriaxone. We are still debating if it was because of the severity of the infection or if it was because of the drug. It's very important to know that we have new molecules of polymyxin that are currently under development to have the best characteristics of the molecule. That's the high in vitro activity against Riley resistant pathogens, but we'd like to have molecules with less toxicity. And IV fosofmycin, I know that the JAMA article showed that it was not inferior to ceftriaxone or meropenem, but maybe in very selected cases, we could use fosofmycin as an alternative therapy for patients with urinary tract infections caused by susceptible isolates as a carbapenem-sparing regime. So I would like to thank you all, and I hope to convince you that there is still a role for polymyxin B and fosofmycin in the clinical practice.
Thank you very much for your talk, and in the interest of time, I think we'll move on, but thank you very much for your great talk. Our next speaker is Professor Mihaela Lupse. She is a professor of infectious diseases from Romania, and she's worked on procalcitonin since her times as a PhD student. And from my understanding, she's a fanatic about procalcitonin, so I'm sure we're in for a treat on her talk about procalcitonin. So over to you, Professor Lupse.
Thank you very much. In a few 10 minutes, I will try to convince you that procalcitonin is very useful for antimicrobial stewardship and also has a good impact on outcome. Here are my disclosure. And antimicrobial resistance is one of top 10 health threats facing humanity, and is responsible for important deaths, disabilities, prolonged illness, longer hospital stay, need for more expensive medicine, and financial challenges. And the World Health Organization said that one way to help countries strengthen preparedness for emergencies in 2021 is to combat drug resistance. Drug-resistant infection cause around 700,000 deaths worldwide each year, and we expect that till 2050 will be 300 million deaths. Antimicrobial resistance is a natural phenomenon, but it's man-made. And actually, the most important cause is represented by the misuse and overuse of antimicrobials in humans, animals, and plants. How can we reduce this antimicrobial resistance? Maybe if we find a biomarker that is specific for active bacterial infection and offer us a proper antimicrobial therapy decision-making. And such a biomarker could be procalcitonin. Procalcitonin is a prohormone of calcitonin. The normal values in plasma is under 0.5 nanogram per milliliter. Procalcitonin increase in 2 to 4 hours after the onset of sepsis, peaks at 24-48 hours, and has a half-life time of 24 hours. Procalcitonin was described as a diagnostic marker of sepsis in 1993. And now we know that low levels or high levels of procalcitonin can discriminate between viral and bacterial infections. And Surviving Sepsis Campaign guidelines from 2021 acknowledge that a low procalcitonin level may help physicians in a decision to discontinue antimicrobials. In this way, it's possible to do a personalized treatment decision and decrease rates of antibiotic prescription, shorten antibiotic exposure, and lower mortality. A PCT-guided approach can be used in various patients, in outpatients, to reduce antibiotic prescription, especially when PCT is low, for example, for acute respiratory tract infection or for exacerbation of COPD, or in critical ill patients with sepsis or severe bacterial infections like pneumonia, or in emergency department for positive and differential diagnosis of sepsis. There are some situations in which inflammation is very important and physiologically procalcitonin is increased even without infection, such as in trauma or surgery or neonates or postpartum women and so on. But there are also some situations in which we have false negative results, meaning that we have infection without increasing of PCT. Such situations are the onset of sepsis in the first hours, chronic infections such as endocarditis, osteomyelitis, prosthetic device graft infections, some localized infections, or infections due to atypical bacteria. Michael Meissner proposed an update on PCT measurements in 2014. He proposed some cutoffs for which we introduce or we discourage antibiotic treatment, and also for patients with high values of PCT at the beginning for which we introduce antibiotic treatment. We can monitor these patients by measurements of PCT every 24 or 48 hours and withdraw the antibiotics when PCT is low, or continue the antibiotics if PCT continue to be high, or change the antibiotics if PCT increased. There were a lot of randomized trials that try to show that a PCT-guided approach could reduce antimicrobial use, could be useful to reduce adverse outcomes and to reduce mortality. And maybe the biggest meta-analysis is a meta-analysis published by Schutz and collaborators in 2017. It's an update of their meta-analysis from 2012, in which they try to show that for a procalcitonin-guided approach of patients with respiratory infections, it's possible to reduce mortality, treatment failure, antibiotic-related side effects, and antimicrobial exposure. Actually, they show in their meta-analysis that mortality is lower. Also, the antibiotic-related side effects and the exposure to antibiotics is lower for patients with PCT-guided antibiotics. But the treatment failure, the duration of hospitalization, and the duration of hospitalization into the ICU was the same, not significant difference between the two groups. Experts propose an international consensus on optimized clinical use of PCT-guided antibiotic stewardship for patients with severe illness in ICU. And for this, they propose a cutoff of 0.5. Below this cutoff, the recommendation of antibiotics is only based on clinical judgment. And if we start antibiotics, it's necessary to measure PCT after 24 or 48 hours, and if the value continues to be low, we stop the antibiotics. If PCT is above 0.5, the recommendation of antibiotics is high, and for these patients, it's important to measure procalcitonin every 24-48 hours, and if the value decreases by 80% or below 0.5, we can stop the antibiotics. What happened in the real world? Actually, it's a study, a retrospective cohort study published by Michael Broyles, who show us that, for example, for lower respiratory tract infection, PCT testing occurred in 18% of hospitalized patients. And if we discuss about concordance, meaning initiating or withdrawing antibiotics according with a PCT value of 0.25, we observe that antibiotic concordance appear only in 55% of cases. Clinicians continue to prioritize clinical judgment over initial PCT levels when prescribing antibiotics for patients with suspected lower respiratory tract infection. A review of guidelines published between 2009 and 2018 regarding diagnostic and treatment for sepsis and respiratory infection shows that only 12 guidelines recommend use of PCT or stated that it can be useful, but none offer information regarding how often should PCT used or how many measurements are necessary. Here are the results of randomized trial published by Evangelos Giamarellos Bourbulis in 2021 regarding long-term infection-associated adverse events in sepsis. And as you can see, for patients with PCT guidance, the death rate and also the adverse events are lower, fewer in patients with PCT guidance. If we discuss about COVID-19, we know that we used a lot of antibiotics for patients with COVID-19. Actually, Michael May published a study in 2021 in which he included almost 2,500 patients with COVID-19. These patients were followed for bacterial complications such as bacteriuria, bacteremia, and bacterial pneumonia. And Michael May showed that only 6.1% of these patients developed community-acquired infections. Also for these patients, PCT was useful because PCT was significantly higher in patients with community-acquired infection compared with patients without community-acquired infections. And actually a cutoff value of 0.25 has a very high negative predictive value for bacterial infections, while a cutoff value of 0.5 has a acceptable specificity for bacterial complications. Take-home message: antibiotics can be avoided or the duration of therapy reduced without increasing mortality in a broad range of acute respiratory infections patients with non-elevated PCT levels. PCT-guided antibiotic prescribing for acute respiratory infection offers a personalized approach to patients more likely to have an acute bacterial infection. The PCT thresholds above which antibiotics are indicated can be adjusted for lower and higher risk settings, and implementation barriers include clinician acceptance and access to PCT. Thank you very much.
Thank you, Professor Lupse, for a great talk. We have a couple of questions from the audience. The first one is, we have seen an impressive increase in PCT in critically ill patients with COVID-19 who don't have bacterial infection. Has anyone else observed this, or perhaps have you observed this, and any idea why?
Yes, we also observed that PCT, especially in ICU patients, could be high. And also Professor May, in his study, observed that it's possible to have high values also in patients without proved infection. Of course, PCT increase in high inflammation, and for patients with critical COVID-19, the inflammation is high. The inflammation is responsible for the critical evolution. And that's why we could have PCT with high values in ICU. Maybe in ICU, PCT is not so valuable for patients with COVID-19. But we know, actually, at least in our hospital, the use of antibiotics is very important, not only in ICU, but in all other wards.
Thank you. One next question is, why don't we use PCT in postpartum patients?
Because in postpartum patients, PCT is physiologically increased due to inflammation, so it's not a proof of bacterial infection.
Thank you. I think that answers all the questions. Professor Lupse, once again, thank you very much for your great talk.
Thank you very much.
So thank you everyone who are tuning into session 5 that draws to an end now. Thank you very much for your time. We just have a couple of slides we'd like to share with the audience before we end the session. Once again, we'd like to thank all the sponsors for sponsoring this wonderful Congress. And giving us an opportunity during this pandemic to get together and talk about infection and sepsis. And of course, just a plug to let everyone know, and also to let your friends know who could not join us today, that all of the sessions will be uploaded to YouTube and also Apple Podcasts in due time. They will start uploading on May the 3rd, and they will be uploaded in sequence, I think every other week or every 2 weeks, so watch that space. And of course, a plug for the Global Sepsis Alliance and also for the regional alliances. Please join us and on Twitter, Facebook, LinkedIn, and also Instagram. And don't forget to sign the World Declaration on Sepsis. And last but not least, please join us in thanking all of our speakers who've given us wonderful topics and talks, and definitely very stimulating session.